Good afternoon. It's 12 noon, and we will get started. As mentioned, those of you who are at the Glen, please feel free to join us in room D02-1312. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Before we begin, just a reminder to please leave your questions till the end of the presentation. Please enter them in the chat. As well, please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you were present today. And finally, we have two speakers today, and I will introduce our first speaker and ask our first speaker to introduce our second speaker. Dr. Patrick Lawler and Dr. Michael Harhay are here today to speak to us. Dr. Lawler is well known to many of you, a clinician, scientist, and associate professor here at McGill University, as well as at University of Toronto. He is the director of the Cardiac Intensive Care Unit here at the MUHC. He is an associate professor of medicine, both here and in Toronto, and his research employs Bayesian adaptive platform, randomized clinical trials, clinical epidemiology, and translational methods. He has a focus on methods to identify heterogeneity of treatment effects in clinical trials. He has led numerous randomized controlled trials in acutely and critically ill patients, and has also supported design and implementation of others. His research team has been funded by over $35 million from the Canadian Institute of Health Research, the US NIH, philanthropy, and others. I could go on, but I think I'll stop there. And I'll let Dr. Lawler introduce our guest visiting professor, Dr. Michael Harhay.
Thank you, Dr. I appreciate the merciful stop. It's a privilege to see everyone, a privilege to be here, and I'm really a privilege to introduce my friend and colleague, Dr. Michael Harhay. Michael's a statistician with particular emphasis on the Bayesian statistician at the University of Pennsylvania, where he directs the Center for Clinical Trials Innovation. Michael has had numerous years of experience, I think, really leading transformative ways of thinking and transformative analytic frameworks, whether that relates to the design of clinical trials in critical care, focusing on individualized treatment effects, as we'll talk about today, or otherwise focusing on new endpoint science and innovative statistical methodologies. I think, Michael, whatever the sort of most recent progress that we've made, Michael is always somewhere in the mix in that sort of wave. So it's been a real privilege to know him for, over the couple of years that we've had the chance to collaborate together. And so we're excited to join you today and talk about estimating treatment effects for individual patients using randomized controlled trials, opportunity to rethink how we treat and define diseases and critical illness. So I will just quickly show that we have some disclosures, most of which, or almost all of which, I would say, don't relate to what we're going to talk about today.
Great. Thank you, Patrick, and thank you for coming and joining online. So first, just to say thank you for hosting me. I love Montreal. I think in North America, it's my favorite city, definitely top 5 globally, and just a really pleasant trip and great host. I once saw an opening of the talk, and it said, prepare people with some good information up front, maybe share a book, and if they really like the book, then they'll just remember your talk is positive. So I want to do that, but also start with kind of this anecdote that I think will sum up and we'll use as kind of a map to guide us through today. So the book is End of the Average, and one of the things I've been trying to do at Penn over the last year is learn from other departments, and I'm going to other seminars, and I keep on noticing that a lot of people in science are dealing with kind of the same conceptual or fundamental problem, but approaching in different ways, and this really resonated for me. So this talk was in our operations department, and it's presenting this, and the story goes back to the 1950s, and it's the era of jet-powered aviation, and as you may have heard of something popular in the United States, the military is building up, and they're building lots of aircrafts, but they're having a huge number of crashes. And one day, the crash rate actually hit 17 deaths in one day, and they're trying to figure out what's wrong. And obviously, people are crashing and dying. It's very hard to figure out, from a detective perspective, what's going on. So he hired this young lieutenant. He starts to interview pilots, starts to measure them, and he starts to figure out that the way that the cockpits are designed in aircraft is built on something that was identified from the US Army in 1926. And he measured 4,000 pilots, and he chose 10 critical dimensions, like waist, arm to shoulder, or shoulder to wrist length, chest width. And he noticed that on those 10 dimensions, not one pilot he measured actually fit what the cockpit was built for. And only 3.5% of people measured fit on 3 dimensions. So the real kind of fundamental problem was that people were flying planes that weren't fit for them. And they had this big approach where they said, okay, we're going to make the cockpit modifiable. We're going to start to allow movable chairs, movable pedals, and then the crash rate immediately dropped. And that's really resonated with me about how we in society, and as a statistician, I see a lot of what we do as trying to deliver based on average and what we're learning by distributions at large. But there's a lot of heterogeneity in those distributions. And what we'll try to do in a tag team way today is talk about the biology underlying them and about the statistical approaches to identify and try to be actionable about those distributions.
Thank you, Michael. So this next slide is a summary of the 17 crashes in one day phenomenon where, as Michael and I both have a strong interest in critical care, we have unfortunately just been plagued with innumerable neutral trials over many years, and really on the for acute respiratory, hypoxemic respiratory failure showing on the left, really prone positioning and low tidal volume ventilation, the only areas where we've made clear demonstrable progress. Similar challenges in sepsis, cardiogenic shock. And overall, it's clear that the method of just sort of applying this framework to what the clinical questions that we've had just has not worked. So for the objectives today, we're going to break it into a part 1, which focuses on how to measure the pilots, or in this case, obviously, patients better. Have we got the right measures? What is the evidence that there is sufficient conservation in the measurements that we think we can actually categorize people beyond the coarse clinical syndromes that we've used? Of course, those syndromes very much defined by a final common pathway for a lot of variability in terms of, the disease pathogenesis and how people get there. In part 2, which Michael will lead, we'll focus on how to design the plans, or the trials in this case, to be more personalized. So how to better restructure clinical trials to accommodate what we think is variability in treatment effect, and then how to talk in more granularity about the statistical methodologies that have come forward that can help us estimate treatment effects for specific patients. And the overall thesis will be to say, in acute or critical care medicine, it may be time to consider changing the conceptual approach to doing clinical trials, moving away from doing a trial that evaluates if a therapy has an effect in a population, to doing a trial to try to estimate what the effect will be in a specific individual patient. And so what we've obviously all been used to over many years is looking at what is essentially an average treatment effect. That's to take a population of people, give them one treatment or the other, and to say what was the average outcome in each group, and the difference must be the treatment effect. Moving instead towards what we talk about, and we'll discuss in more detail, is individualized treatment effect estimation. What we obviously want to do at the bedside is to have a patient in front of us and to make a clinical care decision based on what we think the therapy will do for that specific patient, and to estimate those treatment effects with a number of different methods. We think there are new ways that allow us to do that. It requires reviewing a few assumptions and frameworks, and so we'll first talk about the concept, and at least our belief, that patients, at least critically ill patients, are sufficiently sort of predictable, and that the patterns of how they do clinically and the molecular underpinnings of that evolution are sufficiently stable that we can guide therapeutic decisions based on that. And then the second assumption will be that we can actually design a trial around using those traits with the available and emerging diagnostics to come up with those types of individualized treatment effects. So for the first part, we're going to talk about how to measure the pilots. And we're going to talk conceptually about the idea that even though it's complicated, acute and critically ill patients do manifest more pattern ways than are sometimes evident. We'll start off with a clinical case. It's 2 patients, both 55 years old, both in out-of-hospital cardiac arrest in the coronary intensive care unit with an anterior STEMI. They both aspirated in the field on intubation, both have a component of sepsis and a distributive shock. They both have hypoxemic respiratory failure with a PDAF of 85. Both are invasively mechanically ventilated and bacteremic. One of them, though, clinically at the bedside is warm and on moderate to high dose, requiring moderate to high doses of vasopressors. The other is cool, requiring lower doses of vasopressors. They're both treated with target temperature management, microaxillary circulatory support with an Impella, antibiotics, low tidal volume ventilation, restrictive fluids, elevated PEEP, the usual stuff. And one of them gets better and the other doesn't, gets worse. Question is, of course, why did these 2 patients have different clinical courses? And did the many treatments that they received have different effects? And can we get closer to trying to figure out which are those sort of are the right treatments for that particular patient and which weren't? To take us a step towards that, I want to look at the concept that a lot of diseases that we take care of very routinely are in fact actually quite molecularly diverse, and that we may not really characterize or appreciate that per se at the bedside. This was a study looking at leukocyte transcriptional patterns. So these are white blood cell counts and looking at the mRNA that they express. And it just asked the simple question in patients with pneumosepsis, what if we just sort of organize those expression patterns into just two groups? And let's see how that looks. Well, when you do it, turned out that one of the groups actually was more hyperinflammatory. That was the majority there, 60% or so of patients mapping up to the red patient. And the other was actually more hypoinflammatory. So these were patients that had more features of endotoxin tolerance, HLA downregulation, T cell exhaustion, and they actually looked like they were more immunosuppressed. So they're both types of patients are clinically there with lobar infiltrates and hypoxemia, but very different sort of molecular underpinnings of what's happening in the patients. Outcomes did differ depending on the transcriptional inflammatory subphenotype. And what was interesting in this middle panel was that there was actually quite a strong correlation between those inflammatory subphenotypes and what was seen in both pneumosepsis as well as sepsis related to fecal peritonitis. We extended the findings further by looking at the transcriptional heterogeneity that accompanies large myocardial infarction or big heart attack. And we again observed very similar variation in that type of inflammatory activation. In fact, it actually had quite a bit of overlap with what was seen in sepsis as well. You can imagine conceptually if half the patients are hyperinflammatory and very immune activated, and the other half are hypoinflammatory or more immune suppressed, that all of these years of immune modulation and infection may very well have resulted in a scenario where half the patients were helped, but half or 40% say of the patients were actually harmed, taking an immunosuppressed patient and further weakening their immune system. By contrast, in a hyperinflammatory patient, recalibrating their immune system to a more acceptable level. Perhaps that explains years of confusing results of steroids and a number of other targeted immunosuppressants and sepsis, which have not proven to be effective in unstratified populations. A question that comes up a lot is how much of this is sort of stable? How much of this is random noise? How much of this is situational? Maybe this is different points along a disease severity continuum and you just caught people at different stages. But in fact, I would argue that there's actually quite a bit of reason to think that there might be some pattern, some organization to these patterns. And so this is a really neat Danish adoption study now from a number of years ago that looked at whether adoptees had a biologic or adoptive parent who died of a particular cause. And if they did, what was the likelihood that that child, the adopted child, would also die of that? When they looked at cancer, there was a strong heritable, or I should say strong, risk related to a parent, an adoptive parent dying of cancer, especially at a younger age, very much suggestive of the fact that there were a lot of situational environmental factors that might pass along related to socioeconomic status, smoking, and things like that. For vascular disease, if you had a parent die before the age of 50, you also were quite at high elevated risk of dying at the age of 50 if it was a biologic parent, but not so much an adoptive parent. That risk diminished over time. And that's something that obviously cardiology, we think very much that people that have genetic tendencies towards cardiovascular disease tend to present on the earlier side. And that's where we use an age of 50 usually as a cutoff for family history, 55. What was fascinating, though, was that if you had a biologic parent that died of an infection, you were almost 6 times more likely to die of an infection also than you were if you had an adoptive parent. And that continued to be the case throughout the whole lifespan. So really this concept that there did seem to be some strong heritability into the risk of dying from an infection that really seemed to stand out above a number of different other things that we consider to be conventionally genetic. This was also sort of studied in twin studies, and very similar findings as well were observed. When we take patients and stratify them based on their genetic ancestry and align them with pathogens that have shared endemic ancestry, the expression of immune markers and the rates of bacterial clearance and overall the sort of organization of the host response varies in a way that implies a similarity and a familiarity when the pathogens do have that shared endemic ancestry with the host. Seen here as well, in other words, the concept that the blood cells, the white blood cells that we have, or in this case CD14 positive monocytes, do have a patterned response that reflects the fact that these are pathogens that have co-evolved with these individuals over many years. And so when we talk about a dysregulated host response to infection, which with organ dysfunction characterizing the definition of sepsis, in reality, what we think is that some of these people are actually sort of doing what they're supposed to. And in other cases, it's very disorganized because the host hadn't had genetic time to see, evolutionary time, I should say, to see the pathogen before. And so the response was quite disorganized when they did. Why would some people have evolved to be this way? What would be this evolutionary selection pressure around how we respond to infections? I think this is a really neat example of what might have sort of evolved. And this is an evolutionary biology study that was able to identify old bones and fossils and ancestral bits over time, and able to genotype them and link them with evolutionary changes, in this case in the HLA DRB cluster. And what they show here is that there's a pattern of sort of stability with a number of HLA variants, in this case, one of the particular HLA variants, being relatively stable over many years. I should say this is 0 is the current day, and the BP stands for before present. So the further back we go, it's the more on the right we are. What happens in the red period is you can see there's this big expansion in the number of HLA-DRB1 variant in this particular variant. And the idea is that this was a time period in history where our ancestors, of those of us from European descent, had evolved to a shift from a hunter-gatherer approach to more of a pastoralist approach. And so they very much started adopting for the first time animal husbandry, whether that was sheep or cows, horses. They were some of the first of our ancestors to ride horses, for example. It was a stable source of food. It was a stable source of leather and clothes, and that allowed people with that degree of cohabitation to really sort of increase as a genetic subpopulation. And so they really that subpopulation, which are called the Amnaya, very much expanded in proportionality relative to other hunter-gatherer populations. And as you can see, as they did that, there was an increase in this particular HLA over time. And so why would that have happened? Now we've, it's a little confusing, but we've flipped the axes here. So now the present is over here on the right side. But you can see over time, as we approach the present, these HLA DRB axes dramatically increase. And again, we've seen it down here. The concept was that there have been would have been at the time, obviously, a need for the patient, or excuse me, for the person, to evolve ways to manage the frequency of infections related to the animals that they were in constant contact with. So we imagine these people that are in constant contact with the animals and all the viruses and bacteria that at the time they had. There needed to be ways for those patients to, or those people, sorry, to be able to control the exposures to the infection. And one of those ways seems to have been to activate inflammatory pathways more briskly and to be able to contain infections more quickly. They developed more sort of tuned, hyper sort of vigilant inflammatory responses by virtue of the fact that they were under this sort of constant evolutionary pressure to see these infections and to be able to fight them off before they lost their reproductive health, which obviously drove their evolution. What is very interesting, though, is if we look down here now at the proportion of people that have genetic ancestry related to this particular tribal expansion, the Amnaya, it maps out very well to cases of multiple sclerosis. There's a belief now, because there's a very strong genetic link between HLA-DRB and DRB1 and multiple sclerosis, that there's a degree of molecular mimicry that takes place between the Epstein-Barr virus and some of the viruses that were probably related to the animal practices from 5,000 years ago or so. People in contemporary society no longer face the same types of bugs. We can pasteurize the milk and prevent all of those things. But what's been left over is this evolutionary relic where if we get confused and react over exuberantly with our immune systems to a viral antigen, we end up in this sort of very hyper-inflammatory state. In that case, it likely contributes to chronic autoimmune disease. This was a study that, again, looked at that concept. They also looked at the cytokine release patterns, showing that people that had higher cytokine release profiles were more at genetically elevated risk for type 1 diabetes, obviously an autoimmune disease. And they obviously saw, saw the same thing with multiple sclerosis. Again, a heightened risk of these autoinflammatory diseases related to these genetic loci likely evolved from all of the pathogens that we were co-exposed to over thousands of years. Perhaps all of this is very interesting, but how can we kind of capture this now and bring this concept back to trials? What we would obviously need in clinical practice to start doing this tomorrow would be some kind of a readout of all of these genetic complexities. So how could we do that in a way that could build it into a trial? Well, I think this was a really exciting study that I recently enjoyed reading that looked at the concept that although we take for granted so many things in the kind of clinical variables that we get for patients when we take care of them, one of them, there probably is a lot more meaning to many of them than we sort of think about on a daily basis. So this, for example, is looking at the concept of white blood cell count parameters. And it looks at the idea that although we specify a normal range of white blood cell counts and its subdistributions, in fact, in reality, there might be more patient-specific normal ranges. And so what we could think of it conceptually as a set point would be a standard level that would be an individualized reference range for myself or Dr. Harhay that would get perturbed over time temporarily by an infection or a myocardial infarction or anything that sort of activated the immune system, infectious or sterilely. But then things would level out and they would return back to the set point that was there before. The set points would be conserved, and the set points themselves might potentially be associated with increased risk. So in the lower right-hand panel, this is the mortality related to just what basically your average white blood cell count is. And you can see an overall, even adjusted for all the variables, clinical variables you can imagine, a significant association between what is considered to be the white blood cell count set point for an individual patient and their 10-year risk of mortality. What I think is quite interesting to tie into the genetic aspects that we just talked about, if you look at first-degree relatives, obviously biologically related individuals, there's a relatively strong correlation between the set point and across those related individuals. But if you look at partners now, these are obviously, and hopefully in most cases, unrelated individuals, and you can see there really is not much of a difference here. So obviously the correlations here, the scale is different. These are very low, and these are obviously relatively high for two individuals where there's a lot of other stuff likely related to that. With that, we can estimate what we think the heritability of a set point would be, and it, as kind of outlined, does seem to be fairly strong. So there really is, even though this is something that we look at white blood cell counts all the time, in reality, there probably is a lot of conservation and a lot more meaning perhaps into what we look at. We sought to extend those findings by looking at just simple metric of relative neutrophil and lymphocyte abundances, obviously also derived from the standard CBC, showing now a population of individuals that survived a major infection and asking the question, well, what happened to them from before to after they survived the infection? We see a distribution of these ratio variables here relative to the frequency. And then I'll bring us down to the lower right-hand panel where you see that this is a cohort of 37,000 patients. So although there's a few people where the numbers really differ from before and after, the relationship of the neutrophil to lymphocyte ratio before sepsis is very strongly correlated with that individual patient's value after sepsis. So the correlation was about 0.5. Most people returned back to their pre-sepsis level after they survived the severe infection. So although acutely perturbed, indeed, we saw the same thing with this relative proportion of innate neutrophil and adaptive lymphocytic responses after an infection. And we also saw that ratio itself is significantly associated with longitudinal risk, and that the context of the risk seems to both be related to relative neutrophilia as well as relative lymphopenia. So it's, of course, not just about the immune system. We focused a lot on that because there's a lot of evolutionary biology reason to think that there should be some conservation and some patterns. But in some of our other work, we've looked at the concept of, how we deal with infections, obviously interacts both with the immune system, but also with ancillary pathways. So as an example, bacterial cell wall products are obviously hydrophobic. They are just like lipids like free fatty acids or LDL cholesterol required to circulate in circulating lipid and protein assemblies called lipoproteins. And lipoproteins are the vehicles by which things like lipopolysaccharide or lipotritic acid are cleared from the bloodstream. So when gram-negative bacteria got into this 57-year-old patient's bloodstream, it was her lipoproteins that were involved in clearing that, bringing it to the liver, and then degrading those in lysosomes. What we said is if that's the case, then anything that increases the availability of hepatic LDL receptor would theoretically accelerate the clearance of those lipoproteins and might reduce the number of the concentration, I should say, of lipoprotein, immunogenic lipoproteins from the bacteria in the blood. So we looked at patients that had genetic variants that would increase LDL receptor availability in the liver, and we showed that was associated with significantly improved survival. The more variants you had, the more increase in LDL receptor you had by extension, the better your survival was. And we also showed that in mice now that were either treated, they were inoculated with Pseudomonas, and then they were treated with blockers of PCSK9, which is involved in the normal degradation pathway for PCSK9 for LDL receptor bioavailability, that they actually had worse outcomes if they weren't treated. And if we blocked PCSK9 and therefore upregulated hepatic LDL receptor, they survived a lot more. So all that to say, we obviously have, as cardiologists, taken full advantage of PCSK9 as a genetic variant, which led to the discovery of alirocumab and evolocumab, and also now inclisiran, which are strategies that we use to lower LDL cholesterol from a cardiac prevention perspective. But it's entirely possible, and I would say probably even probable, that some of that selection pressure related to infection was probably what drove an enrichment for some of these genetic variants over many, many years. And again, understanding how the host and the pathogen have co-evolved, suddenly this seemingly sort of randomly present variant makes a lot of sense, I think, and we can understand this. So last slide on this kind of conceptual framework to just sort of say, it's obviously, of course, not just about, genetic risk, that there's many things that happen to us, obviously, over time, whether that relates to classical immunologic memory, or obviously what we increasingly appreciate as innate or trained immunity. A lot of stuff happens over time. And so the way that we react to an initial infection is different than the way that we react to subsequent infections. And that's true both just obviously for our adaptive, but also our innate immune arms as well. But it does seem to play out in predictable patterned ways if we stop to look for it. So for a number of years, we've sort of spent a while trying to characterize the, what those patterns look like, and understanding what the subphenotypes are and how people with a broad clinical syndrome could be better stratified, with the idea that we could then make better treatment decisions if we understood better who the patient in front of us was from a molecular standpoint. And we've spent years, I would say, kind of characterizing the syndrome substructure based on the disease traits. But I think it's time now to move towards trying to characterize it, syndrome substructure, based on treatment response now. So in all cases, we've been talking about measuring the pilots. How do we figure out, what is the right measure? Is it the waist? Is it the height? Is it the, where their eyes are going to sit? I think we've gotten closer to sort of characterizing that in a very descriptive way. And now I think it's time to start to move more towards treatment response. And so what I mean by that, before I hand over to Dr. Harhay, is that we've, as I mentioned briefly in the very beginning, when we do clinical trials, of course, we treat people with experimental treatment versus a control. And we look to see what the event rates are across both of those two groups. We take the difference and we say, well, that's what the treatment does. This is what aspirin does. This is what, simvastatin does. This is what antibiotics do. And that is essentially an average treatment effect for everybody in the trial. We obviously, though, think that the people in the trial, like we've sort of said, are very diverse, and that we don't capture that diversity very well, nor do we potentially capture the implications of a treatment strategy for an individual patient by just looking at the overall average in the clinical trial. In some cases, that might not matter. Like in some cases where we're talking about a relatively low risk, easy, cheap intervention that can be applied in a population health way, it may not matter what it does for a specific person. The point is it seems to help most people. And so we can put fluoride in the water because everybody's teeth benefit from it. And very few people are harmed by it. But for many things in critical care and in acute care, the patients are complex, the interventions are complex, very few of them have no risks. And so the patients are better sort of conceptualized probably in this framework, which we call an individualized treatment effect framework. It takes that idea of an average treatment effect, which in this case looked like it, favored the treatment a little bit, and takes the idea that there probably are some people that benefited quite a bit from the treatment. There's more of them than were harmed. But there are a bunch of people that probably had where the treatment had a negligible effect, and there's other people where the treatment might have even been harmful. It averages out to an average treatment effect that looks slightly beneficial, but in reality, what we'd obviously like to do for each patient is to say, okay, well, in this particular patient, it looked harmful. In this particular patient, it looked helpful. And we, of course, appreciate a broad diversity and eventually would like to try to, derive more specific effect estimates. And one way to do that is with stratification, where we would say, this is a subpopulation where the treatment looked harmful, and this is a subpopulation where the treatment looked helpful. And we're obviously going to give it to these people and avoid it in these people. Option two, which would be really nice, would be to actually say for each specific patient, we think you're going to have a 2.5% absolute risk difference in death if we can treat you with this treatment. In other words, to provide them an individualized treatment effect rather than an average treatment effect. So how are we going to do it? I'm going to hand it over to Dr. Harhay to tell us.
Thank you. Okay, so what I'll do over the next 10 or 15 minutes is try to teach you about the statistical thinking and some of the history about how we've come and evolved to answer the question that Patrick outlined for the last 15, 20 minutes. So this kind of chasm between the average treatment effect and individualized treatment roles. I love working with clinicians, and I teach a lot in our clinician programs. And I think as a statistician, I really like to focus on statistical thinking. So it's not about equations, but what I kind of want to do is demystify a lot of the words you hear. So I'll try to accomplish those kind of various goals in the next couple minutes. I'll start off talking about what is heterogeneous treatment responses from a statistical perspective, some ways to model them at a conceptual level, and the advantages and disadvantages. And what I'll close with is an area that is called causal Bayesian machine learning, which is my primary area of academic research. And I know it sounds like a lot of words, but what I want to do, as I just mentioned, is kind of demystify it and show you kind of what we're doing. And I think you'll see it as rather simplistic and maybe even attractive. And if it fits any of your research, I'd love to hear more from you. So what you've been hearing for the last couple of minutes is a biologic argument about different responses to treatment. And this is kind of the idea. So we have this line of neutrality or null. And the idea is that every patient kind of has two hypothetical ways that they could respond in a trial. One is no response, or they could have a harmful response. And that could kind of go both ways. And the idea is that you have this variation happening in a trial, such as some people are benefiting, some people are being harmed, and some people are having no effect. And the idea there is that there's non-random variation because of something about the individual. It may be measurable, it may not be measurable, but there's patient characteristics that are underlying there. And the logical conclusion is that a lot of the clinical trials we've been seeing in critical care, or at least this is a hypothesis a lot of people have in the field, is that we're missing these effects because of this variation. So this is a slide Patrick showed in the beginning. And these are all the ARDS trials that have been done. So this represents about 45 years of research. So going back until the 1980s, late 1980s through to 2014, and about 15 years ago, someone had the idea, like, let's go through these old trials and let's look at the biomarkers and see what we can find. And maybe we can explain some of that potential harm and benefit. And this was using latent class analysis, which is essentially a way of looking at correlations, trying to figure out what biomarkers move together and which ones move away from each other, and how certain groups may look more similar and dissimilar in those movements. And they identified what they call the hypo and hyperinflammatory. And I'll show a little bit more on the biology of that the next slide. But they reanalyzed all these completed trials, which are the little treatment effects I just showed on the prior slide. And he found dramatic differences in the mortality outcomes. So the first trial, the ARMA trial, which is low tidal volumes from mid-1990s, one group had 23% mortality, another one 44 at 90 days. And you can see there's kind of this dramatic heterogeneity in how people are responding to the intervention. Now, that's very informative, but underlying that partitioning of heterogeneity that group have done is a lot of heterogeneity. So here is what a hypo and hyperinflammatory characteristic looks like. You have a bunch of hyperinflammatory in the red here. So high IL-6, IL-8, PA1, other words that I don't know how to say comfortably. And what you see is that there are people that are on one side, and there are people on the other side, but there's a lot of people in the middle. So what we're using from a kind of non-critical way is kind of a crude way of splitting a bunch of people to have some heterogeneous responses. So that kind of brought us up into the late 2000 teens, and the pandemic hit. And this is kind of a lot of the impetus for my own research. And I think a lot of people are looking back on these trials, and a lot of these trials use what I will call fixed design, where we design a trial, we randomize, and then we analyze. And especially in Canada, you've been incredible innovators in these adaptive designs. And these adaptive designs have this idea that you randomize, you start to observe outcomes, you try to understand who's doing well, who's not, and you can kind of adapt your trials as you progress. So part of my whole motivation in my research, and why I want to introduce some of what I talk about today in a Bayesian framework, is I really think the future of academic medicine, and hopefully just innovation and pharmaceutical development, is really driven by Bayesian adaptive trials. I don't want to spend too much time on it, but it's kind of a key component here. So the idea is that you enroll people and the trial never stops. The trial keeps on learning, and it's figuring out who's responsive, who's not responsive. And that requires this kind of adaptive ability to, in real time, learn who's responding and who's not responding, so that we can really realize this heterogeneous treatment response and then adapt to it in a trial framework. So the motivation that kind of brings us to today, and I think the landscape in clinical medicine, is we need practical tools to identify variation proactively, not just looking historically on trials, trying to understand who didn't do well in the past so that we can think about a future trial. We want to move faster and more effectively. I think everybody would appreciate that. we're obviously going to be a little wrong. So we need to be able to quantify uncertainty so that we can make reasonable movements based on how likely we think we are wrong and understanding the consequences of that mistake. We want to produce stuff that's immediately clinically actionable. We don't want to wait years to do these secondary and tertiary analyses of completed data. So part of the reason I wanted to work in a Bayesian framework and talk about that is I think this is generally where the field should go. So with that kind of foundation laid, what do we want? We've talked a lot about this heterogeneity of treatment effect, and I try to avoid equations. So when I talk about ITE, I think a good example, and this is increasingly aging myself to the point where I don't think people even know the movie. But if you know this movie, Gwyneth Paltrow runs down sliding doors and she misses her train and she's really sad here. And then she runs back down and restarts and she gets on her train and she's happy. And the whole movie's about how this one time, this split in time, we observe someone going in two different directions. That's functionally what we want to identify when we talk about individual treatment effect. Now, of course, we can't do that. So that's the ideal trial, but we're stuck with this average treatment effect. So how do you navigate in between the kind of ideal and our average? So we use randomization. I just want to remind everybody what randomization is because it allows us to do cool things in this world of causal inference. So if you picked up a journal in the last couple of years, you've probably seen the word causal inference. So one of the principles of causal inference is making two groups comparable at baseline. There's a lot of other principles, but that's the goal. And this is how it works in a trial, just to make sure we're on the same page as we progress. So we have a bunch of people in our ICU, and there's some blue, some orange, some red. I think the colors got a little scrambled. But the idea is that they have some set of averages. They're expected to be in the ICU for 10 days, mechanical ventilation on average for 7 days. Maybe 30% will unfortunately die in 90 days. The idea behind randomization is you take this overall group and you split them, and at baseline, they probabilistically look the same, and then you can start to make contrast among them. So this is the tension that clinical research in medicine has been stuck in for such a long time. We want this individual treatment effect insight, because that allows us to make this bedside individualized treatment of rules. That's really what we're talking about heterogeneity. We want to be able to make actionable bedside decisions based on the characteristics we see in front of us. It's really much cheaper to have an average treatment effect trial. You enroll much people, it gets done faster. So how do we navigate this? So I caveat that I will offer what I think are some statistical solutions to operate in the current milieu, but I obviously want to acknowledge that we really probably need better and more sophisticated trials. And that's kind of the end realization we'll talk about at the end. But with what we have at hand, I'll talk about what are called conditional average treatment effects, which are essentially what they sound like. They're average treatment effects for a group of people conditional on some characteristics. Sometimes we're not so sophisticated, we make up words. So this idea of conditional treatment average effects is something you've seen and heard before. And I'll talk about kind of the ones you're more familiar with and some of where we're migrating to as a field. So I'll call them Kates. And what I like to call them dynamic subgroup definitions, because at some point we're never really going to have individual level information, but we're going to be able to kind of look at people and talk about this person's in this age bracket, this person has this body habitus, this person has some history of disease, and we can kind of make some probabilistic assessment and plan based on that. And that's kind of where we're moving to. So there's a dynamic element. And I use the word covariance, or characteristics, because we're talking about plural, as I just gave you in my example. So we're really decomposing the average treatment effect into a dynamic heterogeneity of treatment effect assessment. And this allows us to have individual kind of level guidance at a smaller group level. So the most frequent way, and if you would like to read more about this, I'll just put a plug for this paper that was partially led by the practical group. Patrick was on it. They let me hang out too, but it's a lovely, lovely review of treatment effect heterogeneity in clinical research focused on pulmonary and critical care. So we're all familiar with our average treatment effects, the slide that Patrick showed a few minutes ago. We have our average in one group and then our control and treatment. The idea behind a traditional subgroup analysis, what you're used to seeing in New England Journal of Medicine, is in panel B. So you will look at a group 65 years older or not. So we're naturally splitting people up based on some component. The challenge of that approach, as you all are probably familiar with, is people who are above 65 years of old also probably have a higher comorbidity history. They also have probably more medicines at baseline, other characteristics that are overlapping. So just understanding their age alone is not necessarily informative. It's kind of a intuitive capture of other elements. Another approach is to rank people on a probability distribution. So we have lots of probability scores, these kind of predictive models. Apache score is very popular in critical care, Framingham risk score, FIB2, MUHC. There's all these scores that predict how likely is someone to die in 90 days based on some probability. So that's informative, but the problem is I'm a big guy and I have a little bit of a waistline. So I may have a higher probability, even though I'm slightly younger than someone who's older. And then you may have this kind of combination of someone who has a congenital disease, and you may have three of us who have exactly the same probability, but we look very different. So maybe the kind of individualized delivery of medication to those people is not really ideal. This is the kind of same challenge you have in propensity scores. You can match people on a probability, but they can look very different in real life. I didn't put it up, but there's a slide that compares Prince Charles to Ozzy Osbourne, and it says both of them are born in the castle, both of them are the same age, both of them, I think, have a marital history, but very different people. And that's kind of the point. So what's really attracted my research group, and I think a lot of the field, is this concept of effect-based modeling. And the idea about effect-based modeling is a very different way to try to answer the same question. So effect-based modeling tries to estimate the question in this dual world, going back to the Gwyneth Paltrow example I gave you a couple minutes ago. It tries to ask what would have happened if the patient received the opposite treatment they were given in a trial. And we do this by making an equation. An equation we call a model. And yeah, the equation gets really complicated. And I want to kind of show you how it gets complicated without showing you the math. But it's really kind of clever to me. And I think there's a lot of attraction to it. And I think it solves a lot of problems, but also creates a lot of other ones. So I'll try to give you a balanced take on it. This is a hugely active area of statistical research. There's lots of different approaches that are out there. I just want to acknowledge them. People call them meta-learners. They don't have great names like T-learners, S-learners. Vernacular is tough. But I really like this approach called Bayesian additive regression trees. I just want to share some of how they work, but it's a broader area of called tree-based learning. And I really like it. And I don't know, I feel like my goal is to try to convert everybody. So hopefully I'll do some here. So the general idea is, imagine we have two simple parameters. So we have X on the X-axis is X, let's just call it age. And let's just call Y pulse pressure, difference between systolic and delta, diastolic. What you're trying to do in any equation is minimize noise into something that's interpretable. We tend to use means because means are a simple thing, this kind of idea of average. So we're making what's called a regression tree, or tree-based learning. And the idea is that if you know that X is below 80, you can say the mean of this group is 26.2, which means that knowing that someone's simply aged 80 or less gives you a pretty good idea of what their age more or less is. It may not be perfect, but it's roughly there. But then we start to see this upward slope. Maybe I'll use a cursor, sorry, once you look at my suit. So then we can see this kind of step up. And now we say, okay, well, if someone's above 90 or above 80, but below 90, their mean is about 36.3. And that brings us to here. And if you move up to above 100, but above 90, but less than 100, your mean is 42.8. So what we're trying to do is minimize the noise in a kind of scatter plot to make sense of the data we see. And this is really what statistics are doing. And it's really neat because people are doing this everywhere. It's not just in medicine. People do this all over engineering. Airports are using it to try to figure out how to queue airplanes. Trains are trying to figure out when to leave and when to bring tracks in. Everybody's trying to minimize and solve this variation. The challenge that I think really exists in medicine is that we don't live in this kind of two-dimensional world. And when I talk about multivariable regression, I think the best example I ever had is if you've ever been to like a scientific museum, or if you have little kids, you may have seen these Hoberman spheres, these kind of big things that expand. You can think about multivariable modeling as that. You kind of have all these different axes, such you may have 20 or 30 different axes. So you may have someone whose age here is 65, they have steroids, IL-6 volume, they're immunocompromised and have diabetes. So this is where they kind of sit in a really complex solar system of multivariable space. And we need a set of tools that can kind of go through this space and give us kind of a good capture of who these people are and what they look like into some type of dynamic subgroup. So I like trees for that approach, but trees can be very unstable. There's a lot of terminology that calls them greedy. So if you let trees grow as far as they can, these regression trees, they can actually grow so that each individual person has a regression tree. So that's truly individualized, but also probably truly useless. So you need a tree to be generalizable. So you need to grow far enough to be generalizable, but not too far. And there's a lot of approaches out there, and we like this approach called ensemble learning, which basically just means we use a bunch of different tools at once. And I'll just introduce you very high level to what they are, and then I'll give you an example. But one of the things I think is most attractive, if you read a lot of people criticism of heterogeneity of treatment effect analyses, is that they're concerned about false positives. So the way Bayesian works is that you have data or likelihood. So this may be our signal that having your age above 65 is a signal of treatment benefit. But we can use, in a Bayesian framework, priors that sit far away. So priors are a guess, or what I use in this example and what my group uses as a protective mechanism, so that when you take your data that you observe with a prior, you pull back your signal. So we use Bayesian approaches to try to protect ourselves from false positives, because it's very hard to validate and find a trial where you can take whatever you learn about individualized treatment rules and go test it. There are a few examples, but generally speaking, it's hard to find two trials that are perfectly comparable. So this Bayesian approach allows us to kind of do causal inference and protect against some of these false assumptions. So it gives us kind of this built-in element to it. We get these very big trees, but I mentioned a couple slides ago that we use this ensemble approach. And what's neat about the ensemble approach is it's what people call data-driven. So this is a data-driven approach, meaning we don't really control what it finds. We allow it to find what we want. And it creates these very complicated trees. But these trees, as I mentioned, this is the only equation. And don't really look at it, but bear with me for 1 second to show you some of what's here. This is just a linear regression, y mx plus b plus a couple other covariates. And if any of you had a statistician and you've seen their code, it's basically just a line of code. And what you're looking at here are just interaction terms. But what's neat about this is the main effect. But down here we have interaction terms. So what the tree-based modeling does is it allows us to identify individual components of really complex interactions. And what's neat is we don't have to know those interactions. So maybe age has a linear interaction with BMI, but then there's a nonlinear interaction with IL-6. So we can kind of search in a very complex space, what are the relationships that are explaining the response to a treatment? So this is why it's data-driven. And a lot of people are very quick to criticize it as being data-driven for that reason. And they'll say like, well, data-driven approaches can be misleading. You can find things that aren't necessarily there. So this brings us back to the Bayesian approach, and I'll tie up in a few minutes. So one of the approaches that we've been pushing is to kind of take a very principled data-driven approach where we use a limited set of biomarkers or things that are accessible at the bedside so that we can kind of not necessarily know exactly what we're doing, but we can do it in a very principled way. And this is something we've been using to try to understand a lot of our past trials. And by doing so, we can think about clinically actionable and clinically measurable covariates and kind of get to individual treatment rules and say who responded best to our treatment in this phase 2 trial. Or if we knew this about a patient at the bedside, what therapy would we be giving them? And this is kind of the beauty of this BART approach and a lot of these tree-based approaches is that you can use kind of the dynamic advantageous approaches of all of them, but if you use them all together, you can kind of offset some of their disadvantages and you can learn a lot. So just for time, I'll jump over this. I like to kind of probably put a little bit more on my slides. I know they'll be online. We talk a little bit about how to do this. But I wanted to end here and just say, at the end of everything I just mentioned, we are simply not doing anything magical. We're just building a linear regression, like I showed you a few slides ago. And that linear regression can give you 2 lines. It can predict a line among people who had the therapy and then among who didn't. And we kind of take a prediction of what they would have had that effect under those 2 situations. And that gives us a best guess of their individualized treatment effect. And then we make an estimate about what is the effect of a therapy. And then we can start to look and see if we can identify subgroups of people that would have benefited the most. So lots of math, lots of nonlinear math, lots of equations, but underneath it, it's just a simple equation trying to make sense of the data in front of us. Just for some people who do observational research, I just wanted to note that these are entirely transportable. There's some other dynamics, but if people are interested, I'm happy to share some literature. I just want to close with a little bit of an ending, and I'll hand it off to conclusions and talks. So I try to always introduce people to thinking of Bayesian, as I think is very attractive. And this is our BART approach that I mentioned to a trial of dexamethasone of 6 milligrams to 12 milligrams. So one of the nice things about a Bayesian approach, as I mentioned, is that you don't have to worry so much about multiple looks, and you get a lot of different data. And this is what you get out of the posterior. For some reason, this slide doesn't have gray lines, but this is what we actually get out of the model. We actually get an individualized treatment effect for every single person, which is comparing their prediction if they got the intervention versus if they didn't. This I showed on the prior slide. And the first thing you look at is say, okay, on average, is there anybody on the negative side? So this is what I call heterogeneous average treatment effect, where everybody has some benefit, but we have some variation in that benefit. And on the left, we have days alive without life support. On the right, we have mortality. So you want to have more days alive with no organ support, and you want to have less mortality or lower probability of mortality. So everybody seems to benefit. But then you can start to get to these nonlinear relationships I mentioned. So here we're looking at age and we're looking at body weight. And those are what we found were the two biggest predictors of how people responded to dexamethasone. And I'll just end with the regression tree, as I mentioned, can be collapsed into a kind of line, where just a regression line. But what's very interesting about this slide, and if anybody wants to learn more about this, just about how to interpret it, I've written out, and they'll be available. But one of the biggest predictors we found for who responded better to the higher dose of steroids versus the lower dose was body weight. And I think that kind of goes back to this whole theme of being average. People of higher body weight, because steroids are body weight-based, tended to respond better. So by delivering a kind of standardized dose, certain people are not responding as ideally. And this is obviously a post hoc analysis, but if we can learn this in real time, I think it gives us an opportunity to progress and prospectively learn in a trial. I'll hand it back to Pat.
Thank you so much, Michael. I'll wrap it up just by saying that we do think this is an important framework for getting the right measurements and redesigning the cockpit. Put it up also for those that may be watching it later online, a number of pros and cons to the approach, and maybe we'll have time to chat in the discussion. A last little bit tiny shameless plug for a trial that we're leading in part out of McGill and co-leading with Manitoba, which is using a two-stage design, tests the treatment effect across a matrix of potential effect modifiers for looking for heterogeneous treatment effect at an interim initial analysis of 1,000 patients. And then it has a de-enrichment step, focusing its efforts only on the population, the subpopulation in whom it looks like the treatment effect is greatest. And be delighted to go over that trial more. And if you have patients with communicable pneumonia on the ward in the ER, please feel free to page me. Thank you very much.
Big thank you for this fascinating presentation on a really transformative approach to clinical trials. The floor is open to question. There's some questions here in the chat. Are there questions in the room from anyone? Yes, Kaberi and then Dr. Roger.
First, thank you for such an intellectual presentation. It's really cool to have thinkers in our midst, so that's fantastic. I have multiple questions, but I'll ask two. One is it safe to assume that a patient's response at a given point in time would be the same as their response at a different point in time? Is that a fixed property of the person? And then the second is, I think one of the advantages is you're looking at intensive care patients, they're stuck, their behavior probably won't matter a heck of a lot. Their socioeconomic environment probably won't matter a heck of a lot. I think it's reasonable to look at biomarkers and genetics. But if we were to export this out, I think there's a real risk in looking at things we can easily measure biologically, whereas there's a range of other things, whether it is socioeconomic, personality type, family structure, I think you could have a field day. So what are the risks and benefits of this approach? And does it tend to naturally lean more into the biology with implications we may not understand?
Great. You want to? I think that's you. Okay, so I got you covered. That'd be a great question. I think to the first point, in terms of the stability and predictability, it's a phenomenal question. In some of the leukocyte transcriptional studies, they've done longitudinal measures, and for the most part, people don't really cross over. There's a little bit of crossover. Some of that probably reflects the fact that, whenever we sort of split a Gaussian distribution in the middle, there's probably a lot of misclassification for people that are on just one side or the other of that, say, median split. In work that we have funded in part that Nadia is part of through some of the innovation funds, we're doing studies where we take patients going for cardiac surgery, isolate viable leukocytes, CD14 positive monocytes, stimulate them with immunogenic stimuli in vitro, look to see if we can predict the inflammatory response and to see if that maps out with what they had during their cardiac surgical response. We've completed recruitment of 300 patients, and we're starting the analysis soon with local funds. Thank you. But in terms of the second question, one of the neat aspects of this is Mike can say a lot more, but it really does incorporate interaction structure in a much more sophisticated way. And so, as you say, whether that complexity is sort of at a particular cross-sectional moment for a patient in the critical care unit with lots of markers and lots of stuff, or whether that complexity is kind of longitudinal. I do think there are interactive tests, but Michael, maybe we could comment on sort of the kind of temporal aspects, because there are some methods that are coming out for that.
So I guess I have a two-part answer. The short answer is yes, you can account for the variability. I call these data-driven methods, and that's not necessarily, I think, a misnomer, but they really, you can't measure it, you can't model it. And one of the things I always try to force people to do is not to model everything, is kind of approach these approaches with, or approach the applicability or application of these with a set of hypotheses. So if you have something that's changing over time and you can measure it or proxy it, then let's put in the model and try to understand the dynamics of that. Measuring longitudinal can be trickier in some ways because what happens can change, that the causal pathway is kind of evolving over time. But yeah, I think you definitely can do that. And I think the socioeconomic modeling and relevance of things is something I think misses from a lot of these studies, but would be really important and insightful. But I'm not sure it fully answers your question, but statistically, yes. But can we do it better? Absolutely.
Yeah, great talk. Echo Kaberi's comments. Fantastic story. I wonder if you could comment on the applicability of the approach of BART across the different disease areas. In some disease areas, we've got lots of different predictors that are collected regularly, have solid sort of evidence base that they're a strong predictor. And in other areas, not so much. Does the approach really rely on having lots of information about good quality predictors, or can it be sort of completely agnostic?
Yeah, so this is a tension. So the first Bayesian models were actually, all Bayesian books start with trying to predict people's batting average. And his idea is that you have a wide continuum of batting averages, but a lot of people kind of are closer to the mean. So Bayesian models with that illustration tend to do better with more variation in them. But the more variation you have in them, the more you are kind of at risk for some signal popping up that's not there. So there's always this tension with trying to get as much data in the model, but not having too much, in which that perfect threshold is, I think no one really knows. Like, people can speculate, but so there's definitely an opportunity to be much more extensive. I don't really use this in a more molecular basic science setting, but I know other colleagues who do. It's very powerful for prediction modeling. It can help identify predictors. It can help, we use it in more of a exploratory, explanatory space. So the answer is yes, but I think the way you apply it needs to be more individually tailored to the question. So I always kind of talk about BART as our hammer, that we're always kind of sharpening to do different objectives, but we use it for kind of everything. And if you have a specific case, I'm happy to kind of chat about how to tailor it.
We're a little bit low on time, so just quick responses, please, to the questions in the chat. What kind of sample size is needed for Bayesian machine learning?
It'd be great if that had a quick response. Michael, let's hear it.
I'm looking for a 5-year grant. No, I was just kidding. Well, not really. The answer is less than you would think, but more than probably most trials are targeting. Most of the estimation of a treatment effect heterogeneity is you need about 2 to 3 times of your sample size for an average treatment effect. You can get some benefits because the idea behind power is avoiding false positives and false negatives, that kind of balance. So transferring power in different statistical frameworks will be tricky, but usually you want twice as much as your average treatment effect. But there are ways that you can kind of do better with the Bayesian approach.
What about heritability and Yeah, heritability effects and immigration.
Great question. It's a great question. I haven't seen those studies. Twin studies and adoption studies is for the most part what I've seen is efforts to estimate the heritability for that question. But anecdotally, I would say that we, kind of in our practice at least, think we see patterns, not to sort of profile, but that they're very much could sort of be carried forward. I would think that's likely the case. And then the last question about sort of ethics approvals and stuff for HTE kinds of things. I mean, so far we haven't hit any consternation at all. Like, if anything, this is to sort of say that we think we've been kind of doing all of these trials, like 17 plane crashes a day thing, and generally gotten very little to nothing out of them. In fact, probably misunderstood the signal half the time. I think there's a clear argument that this is potentially deriving more of a patient-oriented, patient-centered effect estimate. And at least in our experience, is predominantly doing stratified designs and getting a number of those approved and already enrolling and stuff. We haven't had any issues.
Fantastic. It's past 1 o'clock, so I will have to close out the presentation, but people are invited to, meet with our speakers who are physically in the room here. Yeah, I think we've answered most of this. So thank you so much. Fantastic. Congratulations also. Really terrific work, and great to have this kind of intellectual presentation that changes the landscape of things, really transformative. So congratulations on that. Thanks everyone for joining. I wish everyone a terrific day.